Hello, everybody, all zero of you who have joined already, and hopefully some folks will be joining soon and watching this also on the recording throughout the week. But welcome to my 3 p.m. Facebook broadcast. Jill is not with us this week, but will be around next week for the part 3 of the edition 3 of the David and Jill show. But we have special guest Lisa Kelly today, and I'll let you tell them a little bit about yourself. But Lisa is a great friend and colleague, lives in Colorado, south of Denver, is a certified team therapist, and has also been helping us a lot with tremendous, generous gifts of time and expertise to try to help popularize a little bit Team CBT as well as my own efforts. And we went on a hike today, went up to the Foothills Park from my home here. We did about, I guess they said 7.5 miles today, and about maybe 90 some flights of stairs. It wasn't a real severe hike, but it was a good hike. Then we went out to dim sum, but we had to cut the dim sum short because we had to rush back to make the show. We were a little behind in schedule today, but we're glad we made it here on time. And I'm going to like Benjamin Mitchell and say hello to Gina Lawrence and like Jill Kelly.
Taylor.
Taylor. Hi, Taylor. We're about to promote your upcoming wonderful training.
Yeah, 12-week class.
Talk a little bit about yourself, and then let's promote Taylor's online thing, and then I'll mention a couple of workshops I have coming up.
All right. So briefly, as David said, I'm a certified Team CBT therapist. I'm from Littleton, Colorado. I've been following David's work for now about 30 years, something like that. And I just feel like any of you would do the same thing for David as I'm doing. I just happen to be fortunate enough to do it, and he's making great strides.
Right. Let's talk about Taylor was in our California Tuesday training group, PsyD, I believe. Right.
Yes.
And possibly a PhD, I can't remember, a doctor of psychology at any rate, was just a wonderful, smart and very personable young mental health professional, and then moved with her husband. And now, third wonderful baby, congratulations on that, Taylor, to New York City, and then started a Feeling Good center in New York City, in Manhattan.
Feeling Good Institute of New York City.
Yeah, and for any of those of you who are in New York and looking for therapy or training, that's a tremendous resource. And also, Taylor is one of a small number of people who are doing Team CBT for children and adolescents, and has a fabulous 12-week class starting this Thursday, and it will be limited to a small number of participants. And it's a chance to meet once a week and learn how to do CBT, Team CBT with kids.
Yes, and I think on April 5th, Jacob Towery, the psychiatrist, Stanford psychiatrist, who also is one of our Team CBT Level 5 trainers, will be visiting online. Why is it, David, you do it much better than I do in talking about all this stuff, and I'm supposed to be the PR person.
Well, anyway,
you do a much better job.
It's easy because I'm enthusiastic about Taylor, and good training and working with children and adolescents isn't widely available, and so you can join. It's an online training. It's probably like an hour and a half a week. And do you have a suggestion?
I have the link. I can't post it now, but I'll just tell you what it is. If you'd like to sign up for Taylor's class, which starts Thursday, you'd go to the feelinggoodinstitute.com/comprehensive-12-a-week-course.
That's too complicated.
I know. Anyway, the feelinggoodinstitute.com, you go on the CBA, what is that? The CBT Academy.
Just go to the feelinggoodinstitute.com, and then you'll see you can click to their online workshops and ongoing training opportunities, and you can find Taylor Chesney's 12-week course starting this Thursday.
Yeah, right. You got it.
And then I'm just put in a link. where I can type in. I don't know if anyone can see it. Maybe I put enter there. Yes, and that's go to myfeelinggood.com to the workshops tab, and I have 2 upcoming workshops that might interest you, and I'm just going to my website right now. One will be March 22nd and 23rd in Lancaster, Pennsylvania, with J&K seminars on rapid recovery from trauma. That's a 2-day workshop, and it may be one of the last times I ever present this workshop live. So if you'd like to hear about some of the new techniques that can bring about, for most trauma patients or survivors, rapid recovery from symptoms, and that would be a great one, a great workshop, and you can use those same techniques with all of your patients struggling with depression or anxiety disorders. So that's the first, March 22 and 23, J&K seminars. Let me just take the phone in case it's somebody saying they can't hear us. Hello? Oh, this is to improve our indoor air quality, so promotion for something. Our air quality is good enough. But anyway, J&K seminars, it's a great 2-day workshop, and I think you'll enjoy that. And then on May 20th, a 1-day work. And by the way, both of these workshops, you can come in person or join them live streaming online. And then on May 20th, I'm going to 2018. I'm going to do a 1-day workshop with Jill Levitt, who is beginning to join me now semi-regularly for these Sunday broadcasts. It's advanced high-speed CBT for the treatment of depression and anxiety. And so you can find links to both of these with all the registration information on my website. You do get CE credits for both of those. And the neat thing about the one with Jill is not only is it just super cool to work with Jill, because she's so warm and bright and clear in her thinking, inspiring, but we're also in the afternoon be doing personal work with those who come to the workshop. If you've been struggling from depression or anxiety or self-doubt, or sometimes feeling like you're not as good as you should be, or beating up on yourself for not being good enough, or from failures or mistakes, that would be a great personal growth workshop for you, because we're going to illustrate some techniques that work quite rapidly and will be powerful and helpful for most of the people who attend that workshop. So here we are now back live again, and I'm liking Taylor again. Taylor says we can hear you and you're doing great. Now we're here to answer your questions. Oh, and Rob is my top guy here from Boston. I just love Rob listens to all of these and makes the most thoughtful comments. It's been to a couple of my live workshops, but I want to take two questions that people have been asking just to get the ball rolling, and then we have more here that we can ask. But if you type in your questions, we're going to give top priority to people who type in your questions. But first, at the end of last week's Facebook broadcast, someone typed in just a minute before we closed, do psychiatrists prescribe drugs too much? And this is something I have pretty strong feelings about, because I began as a full-time psychopharmacologist at the University of Pennsylvania Medical School, and also I was doing research on central nervous system metabolism, this so-called chemical imbalance theory. And let me say right off at the top that sometimes medications are absolutely necessary in treatment and can be life-saving for some people. I've never been against the use of medications where they're needed and where they're effective. But I do think that they are overprescribed, and that many psychiatrists and general physicians will be giving pill after pill after pill and keeping people on medications when there's no evidence of improvement. And this particularly breaks my heart. I've seen so many patients who came to me who have been in treatment for years or decades, and often they're taking 2, 3, 4, 5 medications at the same time, including many antidepressants. And I give them a quick depression test, and they're still severely depressed or extremely depressed. And that's proof that the medications are not being helpful. And I've never been in favor of giving people medications that they don't need or that aren't really helping them. When I was in clinical practice, 60% of my patients I treated without medications at all, and 40% who requested, say, an antidepressant. I was certainly happy to prescribe the antidepressant, but I never treated anyone with drugs only. And even when I treated someone with what in the early days we called cognitive therapy, say plus an antidepressant, I told them as soon as you recover, you're going to have to do your psychotherapy homework, and I'm going to teach you how to manage your negative moods without, the pills. And once you recover and you're really happy and joyous, then we'll taper you off of the antidepressant. And I almost never had any difficulty doing that with my patients. I never kept anyone on antidepressants long term. I had a patient or two who just didn't want to taper off of their antidepressants in spite of the fact that I wanted them to. But I think it's great news that the vast majority of individuals with depression and all of the anxiety disorders can now be treated pretty rapidly with the new Team CBT without having to take medications. When someone has a more severe kind of disorder that is of a biological nature, schizophrenia, bipolar 1, bipolar 2, these are disorders where medications can be absolutely crucial part of the treatment. Now one question that we had, actually I'll answer now, and then we'll go on to the other question. That do people with bipolar disorder, need to take medications, or is psychotherapy alone good enough? And I manage many individuals with bipolar manic depressive illness. That's where people get extreme highs and extreme lows, and can even become delusional during the highs. One of my first patients as a resident that I treated at Island Hospital was a man who was some kind of aeronautical engineer, and he was in the inpatient unit for a manic episode. And he was so uncontrollable, he had to be in leather restraints, and he was being fed intravenously. And he was having the kind of hallucinations that he had caused a plane crash in Alaska, and where many people had died, and he got to thinking maybe it was due to some error he made in the engineering of the aircraft. And I remember the first time I interacted with him, and he was, in a hospital bed in leather restraints with intravenous going, but we formed a connection, a warm connection. And he got over his manic episode, and we got him out of the hospital, he got back to normal, and then he continued working with me. And we had that warm, trusting relationship. And I always felt that was a part of his recovery and treatment. And when I was at Penn, doing my postdoctoral work and my research work, I ran the bipolar clinic, the lithium clinic at the VA hospital in Philadelphia. And that was before I learned cognitive therapy. And it was just pure medication treatment. And I was treating all of these veterans with manic depressive illness, and they were just going in and out of the hospital like a revolving door. The treatment was not very hopeful or successful in my opinion. I was doing excellent state-of-the-art psychopharmacology, but it wasn't enough. And then when I learned cognitive therapy and then developed my own clinical practice, I continued to have referred to me many patients with bipolar manic depressive illness. But in addition to usually lithium, I kept them on for maintenance. And if they got manic, I would hit them with something stronger for a few days to keep them out of the hospital, to cool them down. But I only had one patient in the next 20 years that ever required hospitalization, and he only required one hospitalization. He'd had 17 before he came to me. But I felt that the psychotherapy made a huge difference. Not just the warmth and support, which is so crucial, but also changing your negative thoughts. And a lot of the bipolar patients had perfectionism and basing their self-esteem on their achievements and thinking, I had to be so great, to be worthwhile. And some of them had phenomenally successful lives. The mania, this thinking I've got to achieve so much had driven them to huge accomplishments, but there was also a huge downside in terms of depression and feeling I'm not good enough and that type of thing. And then when they developed unconditional self-esteem, it just seemed to me that their prognosis, the way they did was way better than if I'd been using drugs alone. That brings me to the other question that people have written in about. What do I, David, think that mental disorders exist? Because Thomas Szasz wrote this book years ago, the Myth of Mental Illness, where he argued that the idea that people have mental illnesses is kind of destructive and not really true, and that we're pathologizing people with psychiatry and psychology. And my own thinking, and I'll get your thinking here, Lisa, too, is that the truth is not one way or the other. I think there are some true mental disorders. Schizophrenia is one. Bipolar is another one. Of course, Alzheimer's disease is one. Parkinsonism is a true, brain disorder where there's actual tissue pathology, damage in some way to this or that system in the brain. And so I think that, mental disorders do exist, and it's kind of misleading and cruel even perhaps to say that they don't exist. It seems to be a denial of reality. But at the same time, I think that 90% of what's in the so-called DSM-5, and I probably got one up on the shelf somewhere, but it's this book, the Diagnostic and Statistical Manual of the American Psychiatric Association. Yeah, like here's an example of it here, the DSM-5. And you go through here, and there's all these hundreds of, so-called mental disorders that you could have, according to the American Psychiatric Association. And there's hundreds of them in there. And I think that most of the things that they describe there are not true mental disorders. For example, take the so-called disorder, generalized anxiety disorder. Well, I'm going to ask of those of you who are watching right now, how many of you sometimes get to worrying about things too much? Put your hands up. Yes, and I could see all of you watching, all three of you, that all your hands are up, and that's natural. Worrying is part of what we do as human beings, and it's on a bell-shaped curve. Some people worry very little, and they're just kind of inherently optimistic, perhaps from the moment they're born, and others worry a great deal, and most of us worry, what you'd say an average amount. But according to the DSM, if you worry about two or more things on more days than not for 6 months, on midnight of the, that's what's half of 365? 182 and a half.
Sure.
So on midnight of the 182nd day of worrying, you have a brain disease that you didn't have an hour earlier. Well, that's nonsensical, baloney, Alice in Wonderland thinking. There's no such thing as generalized anxiety disorder. That's just a fantasy. Worrying exists and can easily be treated, especially with the new team CBT things. But it isn't true that people who worry more than others have some brain disease that others don't have. Now, how did this happen? Well, you see, the DSM, the Diagnostic and Statistical Manual, evolved from standardized interviews we used to give to our patients when I was doing brain research. We had a depression research unit at the VA hospital in Philadelphia. And to publish papers, we had to do structured interviews to kind of assign the diagnoses according to strict criteria. so that if others wanted to repeat our research, they could get a similar group of patients. And so the reason that they had all these criteria in these structured diagnostic interviews was so we could have a standardized group of patients that could be replicated by anyone. It was developed as a research tool and should have remained a research tool. But what happened is this slippery slope thing happened where they went from, well, to do research on anxiety, we're looking for patients who have had a minimum of 6 months of worrying. Well, that way, you get a population of people who are really heavy worriers, so you can do a good research study. But then it went from, this is a criterion for selecting patients from research, to these are the criteria for the diagnosis of a brain disorder. That's what happened. And so now psychiatrists are taught there are all these brain disorders, but it's an illusion or a hoax or illogical thinking, however way you want to put it. To me, it makes no sense. And I think the reason that psychiatrists do that is so that they can feel more like real doctors. That the psychiatry has always been like the Lululand of medicine. For a while, Freud was trying to dignify it by, saying we've got psychoanalysis is good for what ails you, and everyone needs psychoanalysis-free association on the couch. And then when I realized that really wasn't working, then he jumped on this biological bandwagon of trying to think that everything is due to some kind of brain disorder that can be treated with pills. And while this makes psychiatrists maybe feel more like real doctors, and then they don't have to learn psychotherapy and they can just prescribe to somebody, or general practitioners as well, they get a patient, and a third of the patients that go to medical doctors or family practice doctors for sore throats or headaches have depression, and then the doctor needs to do something. So we'll give you this antidepressant. He gets them out of the office and doesn't have to deal with them. And I wouldn't be so opposed to it if the antidepressants were more effective. But I think we've been oversold on this model. I think the chemicals called antidepressants we've been oversold on their safety and effectiveness. And in addition, I think most people who were broken hearts, who were depressed or anxious, they need some powerful psychotherapy. And then I usually see, dramatic changes in people very, very, very quickly. So that's my point of view. It's just David's point of view. It's not ultimate truth or anything like that. But thank you for that question. Now let's see what we got here. And also, what is because you've had some personal experience with some of these things too.
You speaking with me?
Well, just in terms of bipolar and like that whole issue. Like, what are your thoughts about what I was throwing out there?
Well, I agree with you completely. It's not just because I'm trained in Team CBT. We have a history of bipolar disorder in my family that. Fortunately, we have lithium available to us, Lamictal, various types of medications, but it still doesn't treat the underlying thought disorder. It still doesn't help you manage your life any better. And so with bipolar, I think it's a matter of medication plus cognitive behavioral therapy or TCBT. I don't think it's either or. I think it's both.
Absolutely.
And I've seen a lot of improvement in some of my family members who have taken that route. As a therapist, I would say many people have been overprescribed by their doctors, and often, and so sadly, with benzos like Klonopin, and feel that they're reliant on them. And then that gets in the way of the treatment of anxiety, because we really can't do an effective treatment of anxiety if you're taking benzos. We have to get the anxiety elevated to a point where you can experience that and realize nothing awful is going to happen.
Yeah, right. Yeah,
so medication can get in the way.
Absolutely.
Can interfere with effective therapy.
Oh, I couldn't agree more. Absolutely.
Mm-hmm.
Now we got some great questions here. D. James Smith, later perhaps could review the basics about refuting irrational thoughts which drive emotions. Well, I have a lot of resources for you on that. I've learned or developed 50 or 100 or more techniques for challenging and refuting the irrational thoughts that create depression and anxiety and shame and inferiority. The next two Feeling Good podcasts, comes out Mondays, and you can sign up for these on my website, feelinggood.com. And they're all published there on my website. You can find them on iTunes and other outlets as well. But tomorrow I'm gonna take the listeners, it's been pre-recorded, step by step through exactly how you pinpoint and refute your negative thoughts. It will be focused on a woman who made a video in my living room a few years back, a woman who was profoundly ashamed, because she was in her third marriage. She was a mental health professional and felt kind of defective and was hiding this from people. And you'll see step by step exactly how to refute negative thoughts. And then a week from tomorrow on the podcast will be another live therapy session with a young woman with profound depression because she and her husband have been having trouble with pregnancy and in vitro fertilization, and then was telling herself, I'm something to the extent that I'm a failure because it's a woman's place to have children. And then also part of her didn't want to have children, and she was also saying a woman should want to have children. If you think you can be happy without children, then there's something wrong with you. And you'll also see exact step by step how to refute these kinds of negative thoughts. Or also you can look at any of my books for the general public. Feeling Good, the New Mood Therapy, shows you how to crush the negative thoughts that create depression and anxiety. The Feeling Good Handbook is perhaps the best one. The book When Panic Attacks. Any of these will give you tons of tools. And there was another question down here.
Gina had a really good one about, is bipolar overdiagnosed? I thought that one was
where is it?
Yeah, it's right there.
Yes, I think bipolar could be overdiagnosed because people get fashionable about applying certain diagnoses, and what these diagnoses come in as fads almost, and then everyone gets diagnosed with it. Right now, a fad is hyperactivity, attention deficit disorder, so everyone wants to diagnose that. The way I have solved that is with my Easy Diagnostic system. It's a survey I've created that mental health professionals can give to your new patients, and then it screens them for the 60 most common DSM diagnoses, so you can apply these diagnoses in a more correct and systematic way. I don't mean to say that bipolar doesn't exist, because it does exist. It's a real animal, and it's very, very powerful and pronounced, and the prognosis is excellent with meds and good psychotherapy. And there was another one here. What do you like about Team CBT? Where are you critical? And then there was another woman here. I'll answer this one first. Jill Kelly. Hi, Jill. Hi, David. I had a question regarding the brief mood survey. That's a survey I've created that Team CBT therapist, I wish all therapists, your patient fills it out before the session begins and immediately after the session, and it shows exactly how much improvement or lack of improvement there is in depression, suicidal urges, anxiety, anger, and other dimensions. And it really helps the therapist see for the first time what's going on, when you're being effective, when you're not being effective. And there are many versions of the brief mood survey, Jill. One has screening for suicidal urges, but there's another one that has screening for homicidal urges.
Good.
And then in case you're working with a very violent population. And then there's a third version that screens for both suicidal and homicidal urges.
That would be nice.
And then in my book, Tools Not Schools of Therapy, there is a chapter which is also in the free upgrade to my therapist toolkit, the prediction and prevention of homicide and suicide. What are the questions you need to ask new patients to assess, if they are going to be at risk for acting out while they're in treatment with you or after the completion of treatment. And then what was this other one? And Ellen, Sam, thank you, Ellen. Thank you, David, for depathologizing anxiety. Yeah, well, you're welcome. You're welcome for that. In fact, we go more than depathologizing, and the team, one of the secret techniques of the new Team CBT is not only to depathologize these things, but to show you what your depression and shame and anxiety and anger and hopelessness actually and defectiveness show about you that's beautiful and awesome. It's not only that it's not pathological, but that actually these feelings often, if not always, come from the part of you that's the most beautiful and most awesome. And that technique has been just mind-blowingly helpful to folks.
Positive reframing is what you're referring to, correct?
Yeah. Yep. Right. Let's see. Dominic says, you're absolutely right. I can tell you from decades of experience that the meds long-term don't work. Yeah. And that's the problem. And again, I don't mean to be overly critical of psychiatry. I am a psychiatrist, but I think that the training programs do tremendous training in psychopharmacology, but not, I think most graduating psychiatrists do not have top-notch psychotherapy skills. And that's why I'm so thrilled that we have a group at Stanford now that meets on Thursday. I have my Tuesday group for community therapists, and we have a Thursday group for the Stanford psychiatric residents. And we had one, Patricia, on today's Hive.
Lovely person.
Yeah, and that a lot of the young psychiatrists are now showing suddenly an intense interest in psychotherapy and ways we can help people without just prescribing something. But yeah,
throwing pills out.
Yeah, and I've seen so many patients on inpatient units and sometimes outpatients who have been on like 6-8 different pills simultaneously for years, and I don't mean to be insulting, but they look like zombies, zombied out, kind of
flat.
Like, flat
affect.
And it's just heartbreaking. Now, sometimes that could be due to the underlying schizophrenia, which has flat affect, but I just
what
think
does Angela have to say? Perhaps the issue with most medicine, physical and mental, is we focus on symptomatology and not cause. I use these terms very loosely. Perhaps root issue may be more appropriate. Money is in solution, drugs, treatment, not prevention.
Yeah, right. Well, at any rate, I think you're right that the pills are somehow trying to subdue these symptoms. And when I used to create and help run the daily psychotherapy, cognitive therapy program at the Stanford Psychiatric Unit, and then here's these patients, the most severe of the most severe, and they're getting electroconvulsive therapy sometimes, multiple medicines, but what they need is someone to say, what is it that's bothering you? What are your negative thoughts? Let's write them down. Let's see what the issues are, and then what we could do to help you challenge and change these negative thoughts, to get at the causes, the root causes, the beliefs that are triggering your depression and anxiety, and to help you. When you change the way you think, you can change the way you feel, and it's just puzzling to me and frustrating and a bit irritating how focused our culture is, thinking that you can cure these things with pills. And if we could, I'll sign up. But I've prescribed personally antidepressants on more than 10,000 occasions when patients asked. And, I haven't seen that much from the chemicals called antidepressants. I've seen amazing things from these powerful new forms of psychotherapy. Let's see. Love TJ Lucian, love the live therapy broad podcasts. How is Marilyn doing? I haven't had touch base with Marilyn for a while. I've sent her, yeah, she's such an inspiration. Marilyn is a tremendous inspiration. I sent her an email about a week ago. I haven't heard back from her. I'm a little concerned for her from a physical point of view, but if I can get some information from her, I'll certainly share it with everyone, because she moved so many people with the live work she did on her stage 4 lung cancer. Let's see. Gina Lawrence, how well does teamwork with PTSD? Well, as I say, I'll be doing a 2-day workshop in Lancaster in just a couple of weeks. I gave the link to it earlier in the broadcast at J&K Seminars on the treatment of trauma, which of course post-traumatic stress disorder is one of the patterns that people can get into after trauma. And I'll show exactly how I treat patients with trauma or PTSD. But let me just say off the top that this, for me personally, has always been the easiest diagnosis to treat trauma patients. And in most cases, I see pretty dramatic changes, often in just a single 2-hour therapy session. So if you're interested, come to Lancaster for that thing, or you can attend it streaming online as well.
So David, I'm going to interrupt you for just a second. One would think that PTSD would be one of the more severe disorders out there. People have been through war or rape or horrific accidents. I would think, or some might think, that these would be the most difficult to resolve. You're saying no, that's not the case. It's probably the easiest for you. And I'm thinking that knowing you and knowing what you've talked about in the past, it would be because it's not what happened to you, it's how you're thinking about it.
Well, yeah, that's the key. The moment you change the way you think, you can change the way you feel.
So how would that work in trauma? Somebody might see mangled bodies on the side of the road, or they may have had horrible experiences in war. That's so traumatic, life changing. Yeah.
Well, you can either throw pills at symptoms, or you can ask the person, what are you telling yourself? What are your negative thoughts? In the workshop, I'm going to talk about a woman that I treated actually at Stanford, who generously agreed to use her vignette in teaching. And she had traumatic events from earliest childhood, sexual abuse, rape as a teenager, other horrible traumas, and then had just prior to my treating her, had another trauma. I mean, she had traumas throughout her life.
So sad.
And then she, just to disguise things a little bit, that she had a hobby. She had a very high profile career in Silicon Valley, but in spite of her enormous success, she had been depressed. She'd been going to the psychiatrist for 30 years and nothing had ever helped. And then she retired. She had this thing that she could do with her hands. I won't say it could have been like playing the violin or whatever. And she thought, well, at least now I can spend, the rest of my life, doing this thing I love. And she had developed a reputation in this other art area, was pretty highly renowned. And then her hands started shaking, and she received a horrible neurologic diagnosis. And so she came to one of the training groups I was doing at Stanford for treatment. And it was very, very moving. What she was going through was realistically horrible. And yet, one of her thoughts was, I'm defective. That was the thought that was causing her depression. And I won't go into all the details of the treatment now.
No following you here.
But once we blew away that thought, her depression disappeared pretty much completely in a single session. And then she had been hiding her diagnosis from her friends out of a sense of shame, thinking that because I have this horrible disease, they'll be pitying me or looking
I
down
must
on me.
hide it, or
Yeah,
I
yeah.
have to hide it. or
Yeah.
my friends will look down on me
Yeah.
if I do share it
Yeah.
with them. They'll
And
judge me.
And also she was thinking of moving to Oregon because they have you can commit suicide there with the help of a doctor.
Assisted suicide.
Yeah, so she was thinking everyone would condemn her for that. And then we gave her an assignment to after the group to share this with her friends, which was terrifying to her.
I bet.
And she came back the next week.
So she used a survey technique, maybe.
Yeah, right. And as well as self-disclosure. And she came back the next week more than completely recovered, actually in a state of euphoria. And she said it was so odd that she's had a life of trauma and unfulfilled dreams and ends up with this horrible neurologic disorder. And now she suddenly finds joy and self-esteem and intimacy and connection with others. I think I love treating trauma patients because most of them don't have the desire to have a life of misery. If something awful has happened to them, and if they could get back to joy and self-esteem, most of them want to. So the motivation is high. Maybe that's one of the reasons that I've seen.
Probably very little process or outcome resistance.
Yeah.
They're all teed up and ready to.
Yeah, we all have some resistance to change, some outcome resistance, but much quicker, much more responsive. Let's see what we've got here. I work with several people who hear voices and wondered if you've ever used externalization of voices with someone who hears auditory hallucinations. That's a great question. Most of the people who are hearing voices, that's one of the common symptoms of schizophrenia, and it's sad. It's a horrible, brain disease. There's some kind of brain injury there, and we don't know yet the cause of it, but it's certainly not a variant of normal behavior. And I've treated a lot of people with schizophrenia when I was in clinical practice, and during my residency at Highland Hospital, we had almost everybody had schizophrenia because it's a county hospital. And so we had, like at our psychiatric emergency room, we had 8,000 visits a month just in that, just there. That was tremendous. And it was very, very, very sad. But my approach has been to help individuals with schizophrenia with the things they want help with, which would be loneliness or dating or depression, but not to try to cause their schizophrenia to go away or to treat their hallucinations, because I never had someone with schizophrenia who wanted help with their hallucinations.
Ooh, interesting. Tell us more about that.
Well, they want help with I'm lonely, or I'm depressed, or I don't know how to get a job, I don't know how to get a date, things of that nature. I learned this early in my career. I had a young man I was treating in Philadelphia with severe paranoid schizophrenia. He thought he was hearing voices and thought people could read his mind. And when he would sit with me, he says, I know that your secretary, Lucretia, is listening in on us right now. And I thought, well, here I can use cognitive therapy techniques to prove to him that this isn't true. So I said, I tell you what, Lucretia's very poor, and I'm going to put $40 here on the table. So I want you to think to her, send her this message that if she comes in the room right now, she can have the $40. And that way we'll know that, she's reading your mind. See, so he closed his eyes and he concentrated real hard, and I concentrated real hard, and Lucretia didn't come in. And I said, what did you conclude? And he said, oh, Lucretia figured out that we were trying to trick her. So she's not coming in. So it was like 0% successful. So I decided to ask him instead with what he wanted help with, which is how to get a date, because he was so lonely.
Isn't that the nature of team, though? It's not what we think the clients need. It's what the client indicates or says explicitly what he or she needs.
Absolutely, and it puts the therapist in a much more humbler role.
Oh, yes.
We're not some expert who's telling people what you should or shouldn't be doing with your life. But it's also a relief not to have to feel like it's your job to change the world.
Yes.
Let's see. Ellen has something for us here.
Oh.
You want to read it?
Hey Ellen, Lisa Kelly here. Nice to see you again. I have just successfully completed an intensive with a young mother dealing with perfectionism, both in her parenting and her professional life. Your chapters in Feeling Good and the Feeling Good Handbook were extremely helpful. I love the methods and the empathy that you supported throughout your writing, and so did she.
Oh, thank you for that, Ellen. And Ellen is, you're always very generous and thoughtful and supportive, and that's always meant a lot to me over the years. Rob D. Gregorio, I recommend your TED Talk from Reno on YouTube to everyone. So yeah, you can find my TED Talk. Thank you for that, Rob. And I talked about my cat Obi, and also when my son was born.
Yes, it was moving, quite touching.
Yeah, we thought he had brain damage. He had to go into the pediatric intensive care unit.
And you held him and you told him how much you loved him. Remember that?
Yeah.
Part?
Yeah.
He came around.
Let's see, Phil, love the show and welcome to Lisa. So welcome, Lisa.
Thank you, Phil.
Can you give more detailed information about the self-defeating belief, emotophobia?
Fear of feeling.
Yeah. The emotophobia is a term I coined for people who are afraid of their some emotions or all of your emotions, and it ties in with my concept of niceness, which is such an important dimension in the treatment of anxiety disorders. And I have 4 basic models that I use to treat anxiety disorders. There's the cognitive model, the motivational model, the exposure model, and the hidden emotion model. And the hidden emotion model states that about 80% of patients with any form of anxiety, could be OCD, PTSD, generalized worrying, a phobia of some kind, performance anxiety, whatever it is, have some kind of emotion that they're not allowing themselves to acknowledge or deal with because of emotophobia or niceness. They think, I shouldn't feel that way.
I can relate to that.
Yeah, absolutely, yeah.
We did some personal work today on my feelings about David.
Yes, right.
There was a little bit of anger there.
Yeah, not terribly skillfully, but that wasn't so much a hidden emotion, but a forbidden emotion.
Yes,
But the hidden emotion model is a little different, where the person can't even bring it to conscious awareness. The emotion that they're sliding under the carpet. Yesterday, I was hiking with Jeffrey Lazarus in the Tuesday group. He's a hypnotherapist. You know him?
Yeah, sure. He's a great guy out of San Francisco. I believe he's a pediatrician.
And then he devoted his life to doing hypnosis with kids, and now he's doing team CBT, and he works with kids with involuntary grunting and so-called quasi-neurologic disorders that seem kind of hopeless, and then he brings about in many of them just a rapid, in just 3-4 sessions, elimination of symptoms. But we were talking about this hidden emotion model, and I gave him the example of a man came to me who was he was an older guy, not old like I'm old, but
not that old.
He's probably 50 or something. At the time, I was probably 32 and thought he was old. But he was this handsome, wealthy guy who was divorced, and he had made a lot of money in Philadelphia, and so he retired at an early age. And then he married this trophy wife, I guess is what you call it, but a younger woman who was also divorced, just this gorgeous woman. And then he had the idea that after they got married, he had all this money so that they'd spend their time traveling around the world.
Absolutely.
And but then she decided she wanted to get a PhD in clinical psychology, and that's a very
demanding.
Very demanding. 60 hours a week. And what happened? He was shaving one day, and he cut himself shaving. It was bleeding a lot, and he thought, my goodness, I might have leukemia.
Ooh.
And so he panicked and went to a doctor, top, blood specialist. They did all these tests and said, no, you're perfectly normal. And he was relieved. Then the next day he got some kind of pain in his head and thought he had a brain tumor. And he went to some high-level neurologist and persuaded them to do all of this evaluation of his brain and imaging. And
I know where you're going with this, David.
Yeah. So that was
that's good. So what did you find out of his?
Yeah. So that
about
was
his hidden emotion.
Well,
He
that
was
was
angry at his girlfriend.
Well, we'll come to it in just a second. But that was normal. So after going to 6 or 7 doctors for symptoms that turned out to be normal, one of the doctors said, "I think you should go get some counseling." So the question is here, what do you think his hidden emotion was? And your guess is anger, and it's a good guess, but it's not a correct guess. But that's what you want to do as a therapist. I'm wondering, could you be
multiple choice kind of thing?
Yeah, feeling angry with
maybe resentful.
Resentful, or you feel kind of like she's not fulfilling her part of the bargain, but it wasn't anything like that. No, what it was,
lonely.
Lonely.
I got it on the third try.
Yeah, right. That he was feeling really lonely, but why hadn't he expressed this loneliness to his wife?
Maybe he was afraid of her leaving him if he expressed these.
Well, that's the question. It was a motophobia. I am not supposed to feel lonely. A man isn't, I'm afraid of that feeling, so I sweep it under the carpet, and then it comes out indirectly.
Yes.
And so the cure was simple, just to have him come in and
did some couples therapy.
Yeah, just couples therapy 101. It took about 25 minutes to get him to open up.
Right.
He was very afraid to do that.
So how did the wife receive it?
Oh, she just hugged him, said, "I've been waiting so long, for you to show your vulnerable self. I just love you so much."
So you had a feared fantasy then. Oh my gosh, if I express my feelings, which I'm not supposed to feel, then my wife will leave me or I'll get this hostile reaction. And that didn't prove to be true.
Right.
So there was some relearning there, I guess.
Yeah. I know you've never had that kind of concern.
No.
But at any rate, there were a couple teaching points here. And one of them is that the anxiety is generally a symbolic expression of the phobia, the feeling that isn't being expressed.
Clear that up for me. I've never really quite gotten that. How does the suppression of the emotion turn?
Well, you see,
anxiety?
what he's saying every week is, "I think I'm dying."
Yeah. Oh.
You see, so he's telling his wife, "You're killing me."
Oh.
My hopes are dying. Yeah.
Oh, okay.
But they don't. It's not intentional. The brain is like creating poetry. Anxiety is like
I've never
poetry.
heard this.
Yeah.
This is really fascinating.
Yeah. Dreams are the same way.
Really?
A dream is a symbolic representation of something you're upset about. If you have a bad dream, it puts it in a disguised format. But it's like once when I had to give a talk in some place up in New York at a hospital, and I wasn't used to giving grand rounds.
Mm-hmm.
I'd been doing speaking, but I hadn't done grand rounds. And so I had to go up, and I was kind of nervous about it. Like, I don't know if I know how to give talks to a hospital of grand rounds.
Yeah.
And I remember I woke up and I had the dream that my jaw was broken. And when I woke up,
metaphorical.
Yeah, I thought it was broken.
Mm-hmm.
And then I said, "Oh no, that was just a dream." And well, it was like by saying my mouth won't be good enough to say something of interest.
That's a real teaching point.
Yeah.
That's
good. So that's one of the things, is that anxiety is generally a symbolic, like kind of a form of poetry for what that emotophobia, the feeling that you're afraid to.
Oh, you're speaking my language.
I
love words in English. That's really interesting. It's a metaphor.
And then the other teaching point was that he and his wife did not need to solve this problem. Someone once said that the attempt to solve problems is the cause of all marital problems, and the refusal to solve problems is the cure for all marital problems.
Okay, it's one of those backwards ways of looking at things, right?
And what it means from a practical point of view is all he needed to do was to be able to share his feelings and be vulnerable and to feel loved and cared about. And then he didn't care about, the travel or the hours. It was feelings.
That secure feeling he had with her.
Yeah, but most couples, they'll start arguing and trying to solve some problem and figure out who is right and who was wrong, rather than becoming vulnerable and sharing feelings. But that's a topic.
I learned a lot
for another day. Let's see. Pick another one here. Here's one by.
Go for it.
It's by Soham here.
Yeah.
Soham Adatia. I wish I knew where he was from, because I don't know what kind of name that is. But we're almost done. Would you believe it?
Yeah,
how can we find something beautiful about negative thoughts? Well, this, if you listen to tomorrow's Feeling Good podcast and one a week from tomorrow, where you see the live therapy, you'll see exactly how we do that. But to just give you a quick example of how to find something beautiful about negative thoughts, let's say you have the thought, I'm a loser, I'm defective,
that would mean I'm humble.
Yeah, well, that's one.
Or that I have high standards. Or
yeah.
I want to be as good as other people.
Exactly.
And that that there are a lot of good things to be done when you're as good as other people and have that achievement level.
Yeah, when you say I'm defective, it also shows that you're looking at yourself in a truthful way.
Absolutely.
Because we all have tremendous numbers of defects, so it shows a kind of humility, a kind of courageous integrity.
Honesty.
Yeah, may motivate you to work hard and to achieve
I'm
a lot.
almost thinking that I would honor other people who I thought I was comparing myself. Wow, they're really doing a great job.
Oh yeah,
that would be an awe.
Absolutely. Like I had roommates in college who were way smarter than I was.
That's hard to believe.
Oh man, they were on a whole. Phil Allen, he's a solid state physicist in Stony Brook now. My ex-roommate Joe Stiglitz, he's received 2 Nobel Prizes in economics, and so I did the thing that I could do, but I knew
So
I couldn't compete with them. But
so the beauty in the negative thoughts, to recap this, is what?
Well, to be honest with yourself, and not to have a false sense of grandiosity or that you're.
So when I say, well, I'm inadequate, well, I would agree with that. I would say, using the disarming technique with that thought, I go, you know what, you're right. I am inadequate.
I have many inadequacies.
I have many inadequacies.
Yeah.
And in fact, I would like to work on some of these areas, and there's a lot of growth in front of.
Yeah, absolutely. But that's just one example. And if you look at the Feeling Good podcast, if I can get some of you to go over and sign up on feelinggood.com, there's a little widget in the top right corner of every page where you can sign up, and then you'll get notifications every time there's a Feeling Good podcast or a Feeling Good blog.
And you also offer them all those back notes into the podcast.
Oh yes, there's show notes, and almost no one
notes.
Goes to look at the show notes.
Yeah,
and like
you're prolific with that.
Yeah, then there's going to be tremendous show notes for tomorrow's one, where we're talking about Melanie, and she felt so defective and so ashamed.
The Melanie videos.
Oh, and yeah, there's 5 or 6 downloads you can do to see exactly how to challenge.
You're going to be selling some of those videos at some point, aren't you?
Well, yes, actually, I've got.
And this is not a pitch. I just happen to remember it.
Yeah, but I've got 600 of these in my garage. Here, let's see. Oh yeah, let's see. Here it is. Yeah, this is the video and the manual.
Well, how do they get them?
Well, I have to go and get the store going on my website. I went down to the.
You're going to create a store on your website.
Yeah, so where they can go and buy it, and I'm going to give some deeply discounted price. And I went to the post office and found out the best way to mail them.
Oh, good.
And there's just a little $6.75 envelope that you can get that it goes out priority mail.
Oh, perfect.
And so I'll be doing that soon. Everything's falling apart here. And then also I'll be writing a lot in the new book that I've been working on, Feeling Great, how to new ways to defeat these negative thoughts. So let's see how we're doing on time. 3:58. See if there's another quick question. We had a couple questions here.
This is one about Christianity. We have to hypomate. Oh yeah, thanks for your books. Very good. I would like to know what you believe about Christian views on depression.
Yeah, well, just to be very, very brief, is that the Team CBT, the kind of psychotherapy we do. I'm not a promoter of religion. My father was a Lutheran minister, and I got pretty turned off by religion because of a lot of the things that I saw that hurt my feelings and angered me, and it seemed more about judging people and sometimes than about love. But there's many theological and spiritual concepts in Team CBT that goes very consistent with the Christian religion, with Buddhism, with the Jewish faith. I would say with virtually every faith, just a simple overlap. One of the ideas in Christianity And again, I'm not a promoter of Christianity or anything, but it's the idea of death and rebirth, or death and resurrection. And one of the themes of recovery from depression is also what the Buddhists call the great death, the death of the self, accepting the fact that we are flawed, and that we're not going to become perfect. And that's really the whole basis of Christianity and the whole ritual of Holy Communion. There used to be a televangelist named Robert Schuller. Do you remember him? He had the Tower of Power from Los Angeles. He had the Crystal Cathedral in Anaheim.
I don't remember,
well,
a lot of our viewers do.
He was, maybe not, but he was one of the, for a long time, he was the top televangelist and just super world famous. He had this fantastic all glass cathedral, and you know how everything in LA is over the top. And then, you know, he was televised every Sunday morning. But he used to hold my book, Feeling Good, up from the pulpit and preach on it. And so many times he did that. And talk about the overlap there between.
You know, that's the first time I've heard that, David.
Oh, is that right?
And I've been hanging around you for the last couple of years. So this was a really good question. Yeah,
I think there's a whole lot to it. And I think it's just good to know that there's a form of psychotherapy that's not going to be in conflict with anyone's religious or spiritual beliefs. And I believe at the moment when you change and have a profound recovery and go from despair to joy, or a conflicted relationship to love and intimacy, that is a spiritual experience. And I've had many patients who at the moment of recovery said, now I understand things from my own religious upbringing, my own religion, that I could never understand before. Some of the mystical, the deeper concepts.
I know we're out of time, David, but I'd just like to remind everyone to send your questions to David at his email at david@feelinggood.com, and let us know what you liked about today's broadcast, what you didn't like, what you'd like to see more of, and anything else you'd like them to.
Well, next week, Jill will be returning for the David and Jill show, so that's something to look forward to. And we thank you all for watching, and we'll see how many views we got. The views went down a lot like this last week. We didn't get only about a third of the viewers that we did 2 weeks ago, and I think many people had trouble finding the broadcast, so hopefully that will go better today, and we'll see. Yeah, do you want these broadcasts to go on? Do you like them? Are there features you want to see? Are there things we can do to make them sexier or neater or whatever? So
and I think we're thinking about having viewers participate with you online, doing some role playing at some point if we can get that going.
Yeah, I don't think you can do that on Facebook. But
yeah, we're looking at that with BeLive TV.
Yeah, but that would allow me to have another guest. You mean a person in the audience to come on with BeLive? Okay.
Yeah.
Well, we might be able to have that.
Would anybody on our viewer list be interested in something like that? Let us know if you'd like to participate in some live role plays with David.
Yeah. So anyway, time to say goodbye. We've had a long day. We're looking grubby. Didn't have a chance to clean up after our hike, but hope you all have a terrific week and are feeling good. Bye.
Bye.